Hi, I'm Joyce O'Shea. I'm a neonatal consultant, and I'm going to talk you through today a video we have made about neonatal intubation. This video is intended as a step-to-step guide to show you what to consider at each stage of the intubation process. It is intended for training purposes only. Prior to the intubation, it is important to have all the necessary equipment ready. You will need an assistant, and ideally the assistant would stand on the right-hand side of the intubator and ideally place their hand on the baby's neck so that you can feel the blade of the laryngoscope. And there also needs to be a clear escalation plan for what happens if an event is unsuccessful. First of all, the baby is appropriately positioned on their back with their head pulled slightly back. If necessary, the shoulders can be supported with a shoulder roll, but this is a bit individual to the operator and to the size of the infant. Baby's mouth then is opened so that you can look inside and you'll initially see the tongue. If there's secretions or anything obscuring the view at this point, suction them. To clearly view the back of the throat, the top lip will need to be lifted towards the nose. Once the top lip is lifted, you'll be able to see the mouth, but the tongue will obstruct any deeper view. The laryngoscope is inserted to sweep the tongue to the left side of the mouth, and then the blade is slowly advanced towards the back of the throat. As you move the blade into the mouth, you look into the mouth and identify the uvula. The uvula is in the midline, then so is the blade. If the uvula is not in the midline, adjust the blade to make it in the midline, and then advance around the corner, and that will hopefully reveal the epiglottis. Once you've found the epiglottis, you lift up and that will reveal the airway as a whole with kind of V-shaped cords around it. Again, there is possibly going to be secretions obscuring the view, but most likely that's not the case if you have a clear view of the airway. It is important to maintain a straight central line with the tongue being held slightly to the left by the blade. We have this real-life picture of this here. You can see the blade, you can see the tongue over on the left, you can see the epiglottis, and then you can see the view of the airway. Once you've found the airway, the laryngoscope blade is generally placed on top of the epiglottis, even though it can be either side depending on how big the epiglottis is and depending on what you're comfortable with. In this, again, real-life picture, the blade is sitting on top of the epiglottis, and you have a nice view here of the airway. Posterior to the airway is the esophagus, and off to the left is the tongue. Then once you have your view, the endotracheal tube is inserted in from the side, and you should be able to see it passing in through the vocal cords. It is almost universal that the tube will be put in too far, but it needs to be measured and left at the appropriate length when you're fixing it. A rough guide will be the baby's weight +6, even though this needs to be a little bit shorter for the very light babies less than 1 kilo. Once the breathing tube has been inserted to the correct depth, the intubator's index finger should be placed in the baby's mouth, holding the ET tube firmly up against the hard palate, and that prevents it moving or slipping while it's being secured. You then remove a stylet, if there's a stylet in place, and attach the CO2 detector, attaching then beyond that to the bag and mask or neopuff breathing apparatus. You then check that the baby's chest is rising and falling with each breath, and that there is misting within the tube, and there should be a color change in the CO2 detector. Once you're comfortable that the tube is inserted correctly, then it needs to be secured. And well done, you've successfully intubated the baby.